another energy presentation. This is funded in part by the NIDDK. And as part of that, we are presenting speakers and seminar series on all sorts of topics related to diet and nutrition and diabetes and obesity and brain and all sorts of really fascinating areas. And Dr. Dominic D'Agostino is one of our collaborators at University of South Florida. He's on systematic reviews with us now, and is second time speaker here in the seminar series, I think, and is just a wonderful, wonderful presenter. So I am going to try. I'm going to try, Dom, see if the AI generated bio is correct. So you correct it if I get anything wrong. I'm very curious here. It seems right. So Dr. Dominic D'Agostino is a tenured associate professor in molecular pharmacology and physiology at the University of South Florida and a research scientist at the Institute for Human and Machine Cognition. His lab pioneers metabolic-based therapies, especially ketogenic diets, exogenous ketones, and metabolic drugs to address neurologic conditions. And please mute yourselves if you're entering. Thank you. To address neurologic conditions such as seizures, brain injury.
Not for students.
There we go. Almost there. And he works also on resilience in extreme environments, including involvement in NASA's NEMO-22 mission. How close was that? Did that get it right?
Yeah, that was right. Yeah.
Okay,
Perfect.
awesome. Amazing. All right. Well, I'll leave it to you. Thank you again for agreeing to speak with us today, and take it away.
Thanks for the invitation and the intro, Josh. Appreciate it. So I will click on to share my slides here. Do the entire screen. Just let me know. How's that?
Perfect. All right.
Okay. And I'm just going to move this little box thing out of the way here. Try to. Okay. Great. Well, thank you again, Josh, for the invitation to present today. And in the intro, today I will be sharing sort of some background information and also on the mechanisms of what we call therapeutic ketosis, which is the ketogenic diet. And we also work on developing and expanding the applications of exogenous ketogenic supplements and I'll be talking about in the context of traumatic brain injury, how therapeutic ketosis and other metabolic-based treatments can be therapeutic for this. But before I begin, my university requires me to disclose our research support. I have a number of University of South Florida patents. They own the patents on various things I'll be talking about. I do a little bit of consulting in this space and a co-owner of different companies that work in this space. We also host the podcast, the Metabolic Link podcast, and we host the Metabolic Health Summit. And yes, nothing I'm saying today should be taken as medical advice. So I want to just quickly probably talk about early experiments on ketogenic neuroprotection. These early experiments that were done at Harvard Medical School and a few other spots really got me interested in the idea of therapeutic ketosis for seizures and ultimately brain injury, which we are working with special operations community now and working on a few grant proposals with them on this. And I will sort of define and what's associated with defining and managing traumatic brain injury. So, and just take, that could be a whole sort of presentation in and of itself, but I've narrowed it down to one slide and really just like, the underlying neurometabolic dysregulation that happens with traumatic brain injury. And this causes many different downstream cascades, including, I'm sure you've heard CTE. I've reviewed a lot of blood work from, military people who've gotten traumatic brain injury. I often see neuroendocrine dysfunction. And so there's a whole cascade of things that happen in a time frame. And it's important to appreciate there's a lot of heterogeneity in traumatic brain injury based upon the type of traumatic brain injury and where it's at. So as you know, the interventions are fairly standardized, as is rehabilitation and follow-up. And my talk is really geared towards sort of those interventions with a focus on building a rationale for ketone metabolic therapy and moving this into sort of the frontline approach that could be used prophylactically, immediately after or during the rehabilitation phase. And there's a number of other emerging TBI therapies, including hyperbaric oxygen therapy, which is sort of a metabolic-based therapy, if you will, delivering oxygen. And we have probably the largest grant ever funded in this space. It's a $30 million grant that's in progress now at the University of South Florida. We have 6 hyperbaric chambers that are being used day in and day out, treating people on this. And it's all blinded, so we don't know the results yet. And we're about at the halfway mark on that. And I'll talk briefly about that. So some early experiments that got me very interested in ketogenic neuroprotection were put on my radar about 20 years ago. And I would like to highlight the work of George Cahill and Oliver Owen. They were the first investigators to establish that the brain has the metabolic flexibility to adapt from using glucose to using ketone bodies, particularly in prolonged fasting or to the point of starvation. So they did a number of elegant studies looking at brain energy metabolism in subjects that were obese and overweight. And this particular study fasted individuals, no food, for 40 days. And they looked at the metabolism of the brain, pre and throughout the 40-day period. These types of studies could not be done today because the IRB ethics committee would never approve such a study. So, but what they elegantly demonstrated is that, over about 7 to 10 days, the main source of energy for the brain switched from glucose, which was essentially 100% brain energy, is derived from glucose in a standard diet in a fed state. And during starvation, approximately 60% of brain energy metabolism is derived from the ketone bodies beta-hydroxybutyrate and acetoacetate. And this is really important because prior to 1967, it was not really known that that the brain had, the ability to use these alternative fuels. So when we fast, we liberate a lot of free fatty acids, and those cannot be used as energy by the brain. So the liver essentially chops them up into smaller water-soluble molecules that can cross the blood-brain barrier and be used as energy. In an extension of the study that was not published in peer review, but it was published in a book and then later in a review, in subjects that had been fasting for 40 days, they injected them with 20 IUs of insulin to produce a level of hypoglycemia that would be universally fatal in someone who, in people that would not be in a state of ketosis. So Drenick also did this experiment demonstrating extreme hypoglycemia in subjects that were in a state of ketosis. So subjects that were induced into this state of extreme hypoglycemia were asymptomatic for hypoglycemia because their ketones were elevated. And, I teach metabolic physiology to the medical students and the PhD students, and we teach that once your glucose gets down below 3 millimolar, you essentially have pretty profound central nervous system dysfunction, and then you go into a coma and then a seizure at below 2 millimolar. So this was really remarkable that, the brain had the ability to use ketone bodies as an alternative fuel. And it caught my attention that this could be used for insulin shock. This could be used for a number of different scenarios if someone was hypoglycemic, to essentially rescue them from fatal hypoglycemia. Although at the time when these studies were done, the only way to produce an elevation of ketones really was extreme fasting or starvation or a ketogenic diet. But it takes a long time to get into a state of ketosis if you follow a ketogenic diet. It takes several days. So those studies caught my attention, and I was funded by the Department of Defense to develop mitigation strategies for oxygen toxicity seizures. And I knew that the ketogenic diet was used when drugs fail for a wide variety of seizure disorders. So in our lab, we have many different hyperbaric chambers where we can simulate extreme environments, including high levels of oxygen that produce seizures. And we have things like atomic force microscopy, confocal electrophysiology, radiotelemetry, where we can look at brain activity and physiological activity under these extreme environments. And we do that in the absence and presence of ketones. So ketones, that we give to cell cultures, to brain slices, or to animals. And we've published a number of studies testing therapeutic ketosis on mitochondria, brain cells, brain slices, rodent models, and in humans. So we do this. We started doing these studies in 2006, and we've gradually moved the science from cell-based assays to animal models, showing that we can have extreme neuroprotection from oxygen toxicity to delay the onset of an oxygen toxicity seizure with therapeutic ketosis. And we can do that with fasting. We could do it with a ketogenic diet, which I'll be talking about, which is the standard of care for drug refractory epilepsy. And more recently, we developed a line of various exogenous ketone supplements. Some of them are actually commercialized, that can rapidly induce a state of ketosis for neuroprotection. And in addition to work we've done in the lab, I've lived in the undersea environment, in a hyperbaric environment, for 10 days underwater, in a habitat that's pressurized and also underwater, doing a variety of different physiological experiments. The bottom picture is me doing psychological measurements, reaction time, decision making, cognitive function on an iDive pad. So in part of a NASA space analog mission. And we also have moved the science of our animal model studies into clinical trials at Duke University. We have 2 registered clinical trials looking at therapeutic ketosis for mitigating oxygen toxicity seizures. So that's a little bit of the background. So I want to pivot a little bit to defining. So what is defining and managing traumatic brain injury? So the causes of traumatic brain injury can be diverse. And, first and foremost, it's falls, especially young children and adults over 65, motor accidents, sports, being struck by an object in the workplace, falling objects, and also violent assaults, gunshots, domestic violence, child abuse, like shaken baby syndrome. And then the classification of traumatic brain injury is typically associated with the Glasgow coma scale, from 3 to 15, and it's looking at eyes, verbal assessments, motor assessments, and severe would be 3 to 8, moderate would be 9 to 12, and mild concussion would be 13 to 15. In addition to that, I'd also like to sort of highlight that there's also, I guess you would call, subconcussive injury, that repeated exposure to certain stimuli, for example, shooting a large caliber gun, like a 50 caliber gun, can produce brain injury, or riding like on a fast boat, which our special operations crew does, like the repeated banging, and that's like, repeated concussion, subconcussive injury over time can also create problems for the brain. So here is the standard of care for traumatic brain injury. And I'm not going to dive deep into it, but I just want to give you an overview of the assessment, what's associated with the assessment. There's a comprehensive neuroimaging, that's associated with assessing traumatic brain injury, looking at the intracranial pressure and monitoring the intracranial pressure is extremely important because there's a number of things that happen, especially with hyponatremia, low sodium. Hemodynamic and oxygenation is really important to get blood pressure corrected, mean arterial pressure, and also more recently, the partial pressure of the oxygen in the brain. There's various ways to do that. And there's people who have had traumatic brain injury are at much greater potential for having seizures, especially if it's a penetrating traumatic brain injury. It's upwards to like 70 to 80% of people with seizures. So that got me interested in, using ketogenic therapies, because that ketosis has profound anti-seizure effects. So I thought that was a good fit there. And also temperature and metabolic, and then various surgical interventions. But what I want to focus on here is really the inpatient and outpatient rehabilitation, the physical, cognitive, speech, mental health, and medication. So these are some things, but ketogenic metabolic therapies they really shine in the context of acute injury, but also the chronic effects that happen, and that could be post-traumatic epilepsy, headaches, and there's also you don't hear about it much, but there's also pretty profound neuroendocrine. So one of my collaborators at the University of South Florida, a recent hire, has really established, and showed that neuroendocrine dysfunction is a hallmark feature of traumatic brain injury. In addition, there's people who have had traumatic brain injury are much higher level, 5 times higher level for psychiatric disorders, including major depression, anxiety, and also substance use disorder. So that could be benzodiazepine drugs or alcohol. And that is something where ketogenic therapies can also be therapeutic. So I want to give like a brief overview of the neurometabolic dysregulation associated with traumatic brain injury, but it's also associated, glucose hypometabolism is also associated in a hallmark characteristic of Alzheimer's disease and also major depression. And with the ketogenic diet or with fasting, when you follow a ketogenic diet or you do prolonged fasting, the liver is the site of ketone production. And when ketones are produced in the liver with suppression of insulin signaling, and after the glycogen is burned up in your liver, you start producing these ketone bodies, and they enter circulation, and they can provide fuel for peripheral tissues, including the heart and most importantly, the brain. And in the context of traumatic brain injury, there's a very significant decrease in the ability of your brain to use glucose as an energy source. So that could be a direct result of physical damage to the vasculature, but also neuroinflammation. And that triggers a disruption of the blood-brain barrier and a decrease in the ability of certain enzymes like pyruvate dehydrogenase enzyme and various glucose transporters like the GLUT3 transporter to be able to use glucose as an energy source in the brain. So these are all sort of mechanistic targets that we look at in the brain. Immediately after brain injury, there's a period of hypermetabolic activity in the brain of glucose hypermetabolism due to the dynamic processes of the injury. And then there's a protracted glucose hypometabolism. And recent experiments, I would say in the last 5 to 10 years, really show that neurometabolic dysregulation in TBI predicts the outcome. It's a hallmark characteristic that predicts the outcome. And you have a hyperglycolytic acute phase, and then you have a hypoglycolytic chronic phase. So traumatic brain injury triggers the swelling of the neurons, the axons, and generates reactive oxygen species. And if we do a glucose PET scan, which is called a fluorodeoxyglucose PET scan, there's a clear indication, especially during the chronic phase of this glucose hypometabolism, that provides the rationale for ketone metabolic therapy. Because as I showed you, that ketones can really largely replace glucose as an energy source in the brain. So I became increasingly interested over the years, especially with communicating with various people that have used these strategies, for their recovery from TBI. And so there's chronic effects of traumatic brain injury on seizures and on mental health. And that there's a rationale that therapeutic ketosis with a ketogenic diet, which is most of the research is on ketogenic diet now, and it's expanding. And I've recently served on study sections for federal study sections and also a foundation study section where they're proposing studies to use a combination of the diet and also ketone supplementation to further augment the therapeutic efficacy of the diet. But it's important to recognize that even mild to moderate TBI can develop into epilepsy at some point. Approximately 20% of people with mild to moderate TBI will have a psychiatric diagnosis within 6 months after mild TBI. And with moderate to severe TBI, approximately 10 to 20% will experience acute or chronic seizures, and 30 to 50% with penetrating traumatic brain injury. Some reports up to 80% will basically be associated with this post-traumatic epilepsy. And then with more severe TBI, 40 to 77% will have psychiatric diagnosis within 1 year. And many of them, depending upon what systematic review or report you read, 37 to 66% of TBI patients will struggle with substance use disorder, in particular alcohol use disorder, and benzodiazepines too, because they have problems sleeping. So, and I bring this up because there are many studies going on now, of course, with the ketogenic diet and exogenous ketones too, for seizures and also psychiatric disorders, including alcohol use disorder. So, so this provides, I believe, a rationale for ketone metabolic therapy. And ketone metabolic therapy is an umbrella term for what could be described as intermittent fasting, which produces a mild state of ketosis, a ketogenic diet, and there are many versions of a ketogenic diet that I'll briefly talk about, and also the development and testing of exogenous ketone supplements. And some of these have been developed through DARPA grants or Department of Defense grants, and also the NIH has developed various exogenous ketones for different therapies. So the ketogenic diet has been shown to be feasible for traumatic brain injury patients. Dr. Maria Edwards, who I was a reviewer of her PhD dissertation work, has done work in this area in Europe. We know that ketones can restore and preserve brain energy metabolism by bypassing glycolysis. Ketones are neuroprotective, cardioprotective, anti-inflammatory, and anti-catabolic. And that's important for the anti-catabolic effects are important for patients that are bedridden due to the immobility with brain injury. And ketones can promote antioxidant effects, mitochondrial function, and mitochondrial biogenesis. So these are all areas of that we research in the lab. But I think it's important to also just to highlight the emerging research on therapeutic ketosis, and that most of these trials, about 80 to 90% of them, are using a ketogenic diet. About 10 years ago, there was probably only about 10 or 20 registered ketogenic diet studies. So on the left, you see evidence-based applications of ketogenic diets, and there's 77 clinical trials on epilepsy and other seizure disorders. There's current trials on Alzheimer's disease, and I'm not going to go through them all, but there's emerging evidence-based applications and clinical trials that are now underway for psychiatric disorders. So that includes bipolar disorders, schizophrenia, major depression, anxiety disorders, things like alcohol use disorder. And also there's 4 clinical trials on traumatic brain injury. So I just took a screenshot of clinicaltrials.gov, the current trials for ketogenic diet and traumatic brain injury. And I've been part of the research with Dr. Maria Edwards, who was really the first to show a diet-induced ketosis in adult patients with subacute acquired brain injury, a feasibility study. So she's recently published this and was reviewer of her dissertation work, and she's also moved this into a study showing the feasibility in post-traumatic stress disorder. Many individuals who have sustained a traumatic brain injury have PTSD, so that's another emerging area of therapeutic ketosis. So we've done some work, which started over a decade ago, on ketone metabolic therapy for anxiety disorders and psychiatric disorders. And it was kind of a spin-off of the work that we were doing with seizure models. We observed that when we administer a ketogenic diet or exogenous ketones to animals, that they were significantly more relaxed and they had less of a fear response. So we published this in probably about a half dozen different papers and review articles. And I believe that, or some of the investigators that are conducting the clinical trials said that was sort of the motivation to start some of the clinical trials that are currently in progress. And I think traumatic brain injury is often associated with, as I mentioned, psychiatric disorders, especially in military personnel that we tend to work with. So I want to briefly discuss sort of the implementation of ketone metabolic therapy. And, clinically, this has typically been with a classical ketogenic diet in the upper left-hand corner. A classical ketogenic diet was developed in 1921 at the Mayo Clinic for epilepsy prior to the advent of anti-epileptic drugs, and is a very high percentage of fat, upwards of 80 to 90% of fat in the diet, very minimal amount of protein. It's not a high protein diet. It's fat and very, very minimal restricted carbohydrates. This essentially mimics fasting physiology. So you have the suppression of insulin signaling, and you have the body is essentially running on fat for energy, as it would when you are in a starvation state or fasting. So there's some parallels there physiologically. There's also the modified ketogenic diets, and then the medium chain triglyceride diet, which is just a greater percentage of a ketogenic fat, including medium chain triglycerides, that makes up the fat. And these diets, it's more liberal in protein, and that can be beneficial too for patients to avert skeletal muscle wasting, and also it seems to be beneficial for kids. We know that higher protein levels in kids from the classical ketogenic diet can prevent the growth restriction that early studies showed. So we have ketogenic diet, ketogenic fats, and now we have exogenous ketone supplements that could be in the form of ketone beta-hydroxybutyrate acids, electrolyte salts, or ketone esters. And we work with them all in various scenarios. So they have pros and cons to each of them. And I think formulation is really the key. And we know that these ketones can circumvent the dietary restriction typically associated with achieving and maintaining therapeutic ketosis. So the ketones, we can measure them with commercially available technologies, including devices like the Abbott Precision Extra or the Keto Mojo device. You can prick your finger just like a glucometer and measure your ketone levels. And that's extremely beneficial in dialing in the therapeutic level that you need. There's also a continuous ketone monitor that you can put on your arm, similar to a continuous glucose monitor. So with a CKM device, similar to a CGM device, we can basically dial in and maintain in real time therapeutic ketosis. So our lab has been very interested in the energetic effects of ketones on the brain, the anti-seizure effects and the neuroprotective effects, and also the neuroprotective signaling associated with being in ketosis. And I'm not going to go through all the signaling, but we know that being in a state of ketosis changes the fundamental neuropharmacology of the brain. So it elevates GABA levels, it decreases inflammation, and there's also epigenetic effects, meaning that the ketone bodies function as a signaling molecule to turn on different gene pathways to activate different genes that are neuroprotective. So here are some of the modified ketogenic diets. You have the classical ketogenic diet, the MCT-based ketogenic diet. So MCTs, when they're consumed in the diet, they go directly to the liver via hepatic portal circulation, and they're not packaged into chylomicrons like long-chain fats. And a large percentage of MCTs are generated into ketone bodies. MCT fats are medium chain triglycerides can enter circulation as medium chain fatty acids, and these can also cross the blood-brain barrier. And ketones, beta-hydroxybutyrate and MCTs can both cross the blood-brain barrier to be used by the brain for energy. There's also a diet called the LGIT, and that stands for low glycemic index diet. And that's a more of like a low carb diet. And this low carb diet also has therapeutic effects independent of ketosis. So we know that simply reducing the levels of carbohydrates can have beneficial effects in different pathologies, including various seizure disorders. So we think the ideal diet would be a modified ketogenic diet, also called the modified Atkins diet. And then you could further augment the therapeutic efficacy of the diet by supplementing exogenous beta hydroxybutyrate as, for example, electrolyte salts. So if you follow a modified ketogenic diet, in the upper right-hand corner, you could see a typical glucose and ketone level. Glucose typically drops a little bit. In this case, it dropped, as an example, to 4.6 from maybe 5.2, and then the ketones were elevated to 0.7. Anything above 0.5 is considered clinical ketosis. So this is just a modified ketogenic diet produces a very modest or mild state of ketosis. So if we take that same diet and we add MCT fats and we add beta hydroxybutyrate salts, we can lower the glucose down to 3.3 millimolar, and then we can elevate the ketones to 3.3 millimolar. So this is an example of a patient that used the diet and then added ketones to further augment the therapeutic efficacy to drop what we call the glucose ketone index. That's that GKI number. A GKI of 1 is the GKI is the millimolar concentration of glucose over ketones. So a GKI of 1 is essentially if you have a glucose of 3.3 and a ketones of 3.3. That essentially shows that you have 50% of the energy in the blood is glucose and 50% is ketones. And we know that that's very therapeutic for managing seizure disorders, also for the metabolic management of cancer. So there are different types of ketone molecules: beta hydroxybutyrate, acetoacetate, and acetone. So what we also know is that there's two forms of beta hydroxybutyrate. We call these enantiomers. They're mirror images of one another. The liver primarily makes the D form of beta hydroxybutyrate, but then it gets interconverted to an L form of beta hydroxybutyrate. And we like to use a racemic mixture of D and L beta hydroxybutyrate. And we've shown that this particular DL beta hydroxybutyrate as an electrolyte salt, which can be consumed as a fruity drink supplement, can enhance neuroregeneration. And we published this a few months ago, demonstrating that we do a simulated scratch assay and we look at neuroregeneration over time, and we demonstrated an increase in neuroregeneration proteins like synapsin and beta-3 tubulin. And in the next slide, let's see. So this is a control. This is an example of one of the experiments that we have where we grow primary neuronal cultures and we do a scratch across the cultures to simulate a traumatic brain injury. And here's a 10-second video. You could see right after we scratch, the opening will get a little bit wider and essentially like nothing happens. That was 24 hours after simulating a traumatic brain injury, which is essentially just a scratch through a neural network on a petri dish. And the next slide shows the same scratch across a neural network. And if you look at the center of the slide, you'll start to see cells kind of migrating and moving into, the next slide here. So here's the next slide where we had beta hydroxybutyrate, the D and the L form in the primary neuronal cultures. And let me see if I can get this. So if you look at the center of the slide, you'll start to see the closing of the gap and the migration of cells into, and that's just after 24 hours. So we saw a significant increase in neuronal migration and also various proteins that are associated with neuroregeneration. So that was with ketone supplements, and we used the same level of ketones that could be simulated with a ketogenic diet. When we do studies in In cell culture or in brain slices, we have to add ketones, and we do it at the same level of a clinical ketogenic diet. But before I go any further, I want to just briefly talk about the side effects of a clinical ketogenic diet. So there are some contraindications. For example, if patients have pancreatitis, if they have liver failure or any kind of liver dysfunction could be a problem. You could also have carnitine CPT1 or CPT2 disorders. So carnitine is very important for transporting the fatty acids. And if you have a carnitine transporter disorder, that could be problematic for people on ketogenic diets. And there's a variety of fatty acid oxidation disorders that are probably more common than people think. And when someone responds adversely to a ketogenic diet, then you have to look at various SNPs and various things that are associated with these fatty acid oxidation disorders. You have to assess vitamin and electrolyte deficiencies. If someone has kidney stones, that could be potentially problematic. As mentioned, carnitine deficiency, primary or secondary. Various bone metabolism in children, that's typically associated with lower protein ketogenic diets, growth impairment, and then lipid abnormalities are also need to be monitored. If someone has, if their triglycerides go up on a ketogenic diet, that's a sign that they're not adapting favorably to a ketogenic diet. So all these things need to be monitored. And it often comes down to formulating the ketogenic diet and personalizing to the patient. There's sort of an art and a science to adapting a ketogenic diet to particular patients because there's a lot of heterogeneity in the ability to sort of to adapt to the diet over time. Some people are intolerant to fat, and the fat needs to be titrated in slowly over time. Also, it's important that there's sex differences in the response to ketogenic diet. And that's another area of research that we're working on. I don't have time to talk about it today, but in epilepsy, we know that amenorrhea can be a problem with more restrictive ketogenic diets, and there's potential reduction of lactation in women that are lactating, and we commonly see a reduction in active thyroid. So reduced T4 sometimes, and also a reduction in the active T3. But this can often be due to just simply a caloric deficit, which can reduce active thyroid. So there are emerging metabolic therapies for traumatic brain injury. Some of these are off-label and some of them are being investigated. For example, you've probably heard a lot about creatine monohydrate or creatine. So this can boost ATP levels by elevating phosphocreatine stores. The amount of creatine typically that's beneficial is pretty high. For someone like my size, that would be about 30 to 40 grams per day of creatine, and that's pretty for TBI. There's research on lactate supplementation, which is also a form of your brain can use lactate for energy as it does it when you're exercising. Your lactate levels go up in the blood, and that can be used by the brain. Mitochondrial antioxidants and other modalities like transcranial magnetic stimulation, photobiomodulation, which activates the mitochondria. Some could say it's potential like a metabolic therapy. And there's hormones and peptides and hyperbaric oxygen therapy. With hyperbaric oxygen therapy, we're doing a large study at the University of South Florida, and there's more recent data indicating that 40 to 60 sessions can improve persistent symptoms years after someone has sustained a traumatic brain injury. And hyperbaric oxygen therapy is much safer in the context of therapeutic ketosis because a limitation is seizures. And with hyperbaric oxygen therapy, so the cutoff is 3 atmospheres of oxygen. So being in a state of therapeutic ketosis can further enhance the safety and the efficacy of hyperbaric oxygen therapy. So I want to talk briefly about biomarker self-monitoring that can be done. This can be done in the clinic or can be done by the patient using blood glucose and ketone monitors to ensure you're in a therapeutic state of ketosis. In the middle panel here is data taken from a patient that has type 1 diabetes. And I want to just show, and I know the individual. So this is one, the top panel of this panel in the middle here shows the continuous glucose monitoring after 1 week. So 7 days in 1 week. And the bottom panel shows the reduction in glycemic variability on someone who is using a very low carb diet, a ketogenic diet, and showing the reduction in glycemic variability. And that's extremely important for someone managing type 1 diabetes because those fluctuations are associated with comorbidities, including early death, cardiovascular injury, inflammation, accidents. So just having lower glycemic variability is really favorable for someone with type 1 diabetes. Also, it reduces the amount of insulin that they need if they're on a low carb diet. So that's an emerging area of research right now that's being done. And the continuous glucose monitors and the continuous ketone monitors are going to be extremely valuable tools for titrating the diet or supplementation for future clinical trials with ketogenic diets. And there's also a number of biomarkers that, and I won't go into all of them, but the top line just shows the CNS and TBI specific biomarkers used clinically. And it's a rapidly evolving area of research, but these are the biomarkers at the top in red for acute understanding of the traumatic brain injury, the extent of traumatic brain injury, and then chronic monitoring. And then we also feel that cardiometabolic biomarkers, and I think it should be termed cardioimmunometabolic biomarkers because there's the cardiometabolic biomarkers are intimately associated with your immune system and your cardiovascular health. So insulin, we know that if your insulin is high, that's associated with poor outcomes in TBI patients. If your high sensitivity C-reactive protein is elevated, we know that that's linked to higher risk, neuroinflammation, and also psychiatric conditions. And you want to reverse the hyperglycemia that's associated with traumatic brain injury. And that could be due to stress hormones or cortisol or a number of other factors, and keep fasting glucose levels low, ideally under 110, and hemoglobin A1C could be monitored. Also, omega-3s in the blood are a really important indicator for overall diet quality, but also the omega-3 levels will predict better outcomes. So these should also be measured, and also B12. If B12 levels are really low, the deficiency can result in impaired brain function. And actually, in our Alzheimer's clinic, one of the things that we look at is that if someone has brain atrophy or mild cognitive impairment, that could actually be reversed with B12 injections. And that's observed in people who don't eat enough animal protein or animal foods. And if they're not supplementing B12, that can be very problematic. And then there's advanced testing that can be done. It's not necessary, but it can be helpful to understand the results of the patient and to adjust and titrate the dietary protocol for brain injury, and also titrate the supplementation. So the omega-3 fatty acid profile is important to look at. And there's also a test called the omega quant test, or to get your omega-3 index. And that's, it can be optimal. And also various heavy metals and stuff should be looked at too, because these things can impede recovery from brain injury. And in military personnel exposed to certain environments, we often see elevated levels of heavy metals, and that can require some chelation therapy and other things to mitigate that. So a number of patients with traumatic brain injury have reached out to me over the years. Some of them have been treated at the VA hospital. So this is sort of someone that the guy on the left was one of the dietitians that I've networked with, and he helped the individual on the right that sustained terrible injury after his parachute did not open. And he was a special operations guy, and he had a very severe traumatic brain injury and with diffuse axonal injury. And he was able to essentially come back from the dead, and he miraculously recovered using, a combination of things. But his dietitian, Trey, was really instrumental in bringing him back, and he is fully operational today and has recovered tremendously. And I think he's 100% back to normal. So here are the current and future research that we're doing in addition to education on this topic. We have pre-dive ketosis for neuroprotection. We have 2 clinical trials that are ongoing and coming to an end soon. And we're developing a wide variety of ketogenic compounds and formulations that can be used for traumatic brain injury. And these are alcohol-free, meaning they don't use 1,3-butanediol, which is one of the more popular commercial ketone supplements on the market right now. Our studies show that you don't want to be taking this at high doses, especially chronically. So we're looking at, developing formulations that work very fast, that can be used orally or intravenously in a powder or liquid form. And they could be used operationally as sort of metabolic preconditioning, and they can be used during recovery from traumatic brain injury. And we also have ongoing hyperbaric oxygen research in progress. And this is it's a state-funded project, and that'll have 420 subjects, and we have maybe about 150 that we've sort of run so far through the program. So that's an ongoing project. And we think that hyperbaric oxygen therapy coupled with nutritional ketosis and supplemental ketosis will be the optimal path forward for individuals as part of an adjuvant approach. So that's, I don't know if someone is trying to ask the question, but here's relevant research from University of South Florida. I'm glad to share the PDF file or the PowerPoint of this presentation. And I want to thank you all for your attention, and would be glad to answer any questions that you may have.
Amazing. Thank you so much. That was absolutely fascinating. So cool to see how far you've taken this from benchtop all the way to clinical trials. So yeah, let's open it up for questions. Thanks for making some time for that.
Sure.
If you could maybe raise your hands in the Zoom. Go ahead, Karen.
Hi, thank you for your presentation. So I was recently speaking with one of my clients who is bipolar disease, and she's on Lamictal and was told that she cannot go on a keto diet because she's using that medication. I wanted to see if you had thoughts on that.
Yeah, this comes up quite frequently. I don't know exactly why. I kind of can understand the rationale for the high-fat diet. So what often happens with bipolar disorder is that they're put on antipsychotics and various anti-epileptic drugs too. And that's why that was almost the rationale for using metabolic psychiatry with a ketogenic diet for bipolar, because the go-to drugs often were anti-epileptic drugs, but also the antipsychotics tend to cause problems with metabolism, including insulin resistance and weight gain. And there's a thought that a high-fat ketogenic diet will further cause the weight gain and the lipid abnormalities that are also a feature of the drug therapy. But in reality, if you have a skilled dietitian that can do a well-formulated ketogenic diet that may be higher protein, high fiber, moderate fat with omega-3 fatty acids and monounsaturated fats, they could transition to that version of a modified low-carb diet and then gradually transition to a ketogenic diet. So that would be my, not medical advice, but that would be my recommendation to work with a registered dietitian that's skilled in implementing these diets. So if you go to the Bazuki group or the disease.
I'm sorry to interrupt you. I'm a certified nutrition specialist, and I've taken various trainings on the keto diet, so I'm pretty well versed in it.
Okay, there's that, but there's also like ketogenic, there's registered dietitians that have been using the ketogenic diet for epilepsy that have now transitioned to being skilled in the art and the science of using the ketogenic diet in metabolic psychiatry. And I think those practitioners have the experience of not jumping the patient into a ketogenic diet, but transitioning them and looking at blood markers like ApoB, Lp(a), and various inflammatory markers that would predict whether or not that patient's going to respond well. So another recommendation could be to not change the diet to, I think diet plays a big role in metabolic psychiatry, but to perhaps just simply add various ketone supplementation. That could be something as simple as medium chain fatty acids or DL beta hydroxybutyrate electrolytes, which is simply beta hydroxybutyrate combined with a monovalent or divalent cation. So these monovalent and divalent cations typically are helpful in people like on lower carb diets, because if they do transition to a low carb diet, because the body tends to deplete electrolytes if you follow a low carb diet. So that can be an adjuvant to a low carb diet if they want to go into that, if they don't want to do a ketogenic diet. So, but this is just based on, emerging area of research. But metabolic psychiatry is its own sort of field that's growing and emerging. And there's practitioners in that field that I think could offer some advice. Dr. Christopher Palmer from Harvard Medical School could be a good contact with resources there.
Thank you.
Mm-hmm.
Catherine, go ahead.
Let's see here. There, I think I'm off mute. So looking at TBIs with these, the ketogenic results are really interesting. I'm wondering if you have had any thoughts about including plasmalogens in some of the TBI studies, because their results on TBIs have been particularly stunning, or if you're even familiar with that research, it's kind of obscure.
Yeah, I'm not familiar, but maybe if you could just briefly describe the rationale for that and which plasmalogens you consider.
So Dan Goodenow has put together an omega-3 derived plasmalogen and an omega-9 derived plasmalogen, both with an alkyl bond that nicely crosses the blood-brain barrier, and he's showing some really interesting research in full remyelination of like Parkinson's, MS, almost any neuroinflammatory disorder, including substantial reversal of TBIs, including very, very old untreated TBIs. So, and it seems like also your work would be a good thing to add into his protocols. And his protocols don't tend to include the ketogenic component. So,
Like, would that be one of the resolvins that have been worked on? So I think I forget the chemical name for some of those fatty acids, but it sounds like the resolvin research that's being done. Yeah, there's no doubt in my mind that certain fatty acids in and of themselves, independent of diet, just as a supplement, have neuroregenerative properties, especially on myelination. And I think that could be a great sort of adjuvant. What the ketogenic diet does approaches the TBI from a brain energy perspective, but also from changing the neuropharmacology of the brain by you make more GABA from glutamate by activating GAD67 and 65. We know, so that's the GABA in the brain that is in the brain comes from glutamate. And with TBI, you often have a lot of glutamate there. And in addition to the axonal injury, which would require remyelination. So I think and remyelination is hard if you have an excitotoxic environment. So I think that could be a good sort of complement to the ketogenic diet to just hit it on all fronts with that. But yeah, if you have any information, I would be glad to look at that and discuss it, and maybe even that contact that you have that's doing that research would be great.
I would, yeah, I'd be very curious. And I'll look at the resolvents as a broader class that wasn't on my radar. So,
Mhm.
can I ask you a question, since you brought up um, GABA? Are you at all familiar with cabergoline as, or just the dopamine agonists, and their effect on GABA? Um, because in my experience, they really stifle responses to GABA. And I'm just wondering if you have any thoughts around that.
Yeah, I know of the drug cabergoline. Yeah, I know of it, but I'm not, as familiar with its antagonistic effect on. I'm familiar with the dopaminergic, effects it
Right.
has, but not as much of the GABAergic
Okay.
effects in this context.
I was just curious. Thank you. It's a
Mhm.
great
Yeah,
talk.
sure.
I think we might have time for one more fast question. Ethel, did you want to? I saw you jump in the chat there. Did you have a question you wanted to ask, or just?
I'm not sure if it's fast, so I just
Okay,
want
well,
to
let's
honor
give it
our
a shot.
time. Yeah. What'd you
Okay.
say?
Anyone else do you want to try to do a quick version?
Um, I don't think that's a good idea.
Okay. Okay. Anyone else last minute for just maybe just a couple minutes left? Quick
I have
question.
a quick question.
Go ahead, Nick.
Thank you, Dr. D'Agostino, for sharing. And I just wanted to follow up on acute versus prolonged
Mhm.
fasting interventions, specifically for treating patients with inflammatory mediated neuropsychiatric pathology. I'm really interested in how neuroinflammation is connected to neuropsychiatric disorders, and especially using fasting therapy as a way to kind of modulate or mediate the inflammation. And so I was just curious if you have any thoughts on acute versus prolonged application.
Yeah, I think fasting can be a very powerful intervention, but you also need to be, cognizant of the prolonged fasting is not advisable in patients that, for example, have a low, BMI, right? So, and maybe it's important to understand what's causing the inflammation. Systemic inflammation is typically associated with neuroinflammation. So when you have systemic inflammation, for example, like if your hsCRP is elevated, that will compromise things like the tight junctions at the gut level, and also you have those same tight junctions at the blood-brain barrier. So and chronic inflammation could be a result of insulin resistance. It could be something in the food. It could be an environmental toxin. But I think fasting is probably the fastest way to sort of reduce, in many patients, not all, the general level of inflammation in the body. And if systemic inflammation goes down, neuroinflammation goes down, and there's so many studies just looking. I was kind of critical of hsCRP as a biomarker for that, but like all the data that's emerging that I'm seeing really shows that hsCRP is a powerful indicator of when it gets elevated, you're more likely to have depression, bipolar episodes, schizophrenia. So anything that moves the needle on that, and we know fasting is a very powerful therapeutic intervention for some people, not all, and bringing that down, I think that's important. But your question is acute versus chronic. Uh, Maybe like, there's like the fasting mimicking diet by Walter Longo. So maybe a protocol could be for someone to do a lower inflammation diet and maybe 3 to 5 days out of a month, maybe do like a modified fasting protocol or something like that. So I've been in correspondence with people that are doing that and also practitioners that are doing that for their patients, and that's working. But with prolonged fasting, you just have to it should be medically supervised. Anything beyond like 2 or 3 days, I think, or 3 or 4 days.
Wonderful. Thank you so much. Another wonderful presentation. Thank you for that, and great questions. And we'll see you again soon, hopefully, in our next seminar. And then we'll be sending out the recording once it gets posted, probably in the next few days. Thank you again, Dom. Really appreciate it. Great talk as always. Take care, everybody.
Thank you, Joshua. I appreciate it. Thank you guys for your attention.